Good morning, friends, and myself, Major Dr. M. Kubek from JK Cancer Institute, presenting you Brachytherapy in Clinical Oncology. Basically, brachytherapy I personally consider is basically a part of interventional clinical oncology. Nowadays, the brachytherapy role getting down and down, and the new centers opening up is not focusing about installation of a brachytherapy, although there is no replacement of a brachytherapy till date. The effect, the clinical outcome of the patients, the small tumor, organ preservation is all included in clinical brachytherapy, interventional brachytherapy. So I'll be dealing you all the basics of a brachytherapy, clinical oncology, few clinical tips in where, what we use, how we use, and what are the components of brachytherapy. So brachytherapy basically was first suggested by the Bell in 1903. That is, implanting a radioactive source directly into the tumor may lead to a significant good outcome of a tumor control. But since 1903 till 1931, the term was given not given a proper, and then Forshell has coined the term the brachytherapy in 1931. And then initially the radium used to be used in the brachytherapy source, but the radium has a lot of problem. The radium is because the byproduct of the radium was a radiotoxic. Radon gas emission was always a problem. A byproduct of radium was a radiotoxic. Along with the contamination of a radon can cause a great problem, mechanical contamination, because of very long half-life, 1622 years. And again, there was a problem, the low specific activity. How we define the specific activity is activity per gram is considered as so the large source size was required so that we cannot put into the finest catheter these radioactive element. And then high cost was again a problem, and then a disposal was again a problem. So multiple problem was associated with the radium, but radium was the first used for a brachytherapy. So that leads to the discovery of many other radioisotopes because of the problem in the radium. So ideal source of brachytherapy should be preferably gamma emitter with energy ranging around 200 kV, should be a monoenergetic, and should have a fairly good half-life for temporary implant, but for a permanent implant should be a short half-life, either few days or hours. There should not be any gaseous product by radioactive element. High specific activity should be there, so the smaller and smaller size source are available so that we can deliver the tumor with the finest catheter. And radioactive elements should be insoluble and chemically non-toxic, should be molded in various size and a shape, can be cutted to the various length, should be a low cost. So brachytherapy sources are available in different forms till date, in form of needle, tube, pellets, seed, wires, which facilitates their application in the patient. The forms of application of brachytherapy was divided into the basically intracavitary, interstitial, intraluminal, surface molds. And the surface mold portion is directly heated by the electron mode of discovery of electron mode of a LINAC treatment. So that's this portion is directly have a neck to head confrontation and a competition with the linear accelerator electron versus the surface mold. So isotopes, I will not go into the details of, you must know the average energy of radium. I've told you the very large half-life, 16 to 22 years, with average photon energy in mega electron volt is 0.832, cobalt 60, half-life 5.26 years, average energy 1.2 mega electron volts, cesium 137, half-life was 30 years, and then average photon energy is 0.662 mega electron volt, iridium 74 days, and average energy 0.38, like in gold. Short half-life 2.7 days. That's why gold used as a permanent implant. And then so you need to remove again that gold seeds. So that average photon energy was low, 0.412. And these are the, I mean, so on, that iridium, iodine, and iodine is more commonly used in the retinoblastoma nowadays, where as a form of a plague therapy. So source stain manual, you can see here the source, how they are. Basically, there are retaining spaces, and then active spacer beads, and then the actual source. And it was all, the source is encapsulated in the sheet, so that the real attenuation is actually compromised. The actual real radioactivity is compromised because of a source encapsulation. You can see a diagrammatic picture of a tumor where the iridium 192 is displayed here in the figure. Here, that you first put like an intracath and a catheter, and then you remove the stillet, then a catheter is remain there. Now with the help of this source dummy wire is introduced, and check and x-ray is done, and then again the real active wire of a radioactive is implanted in the tumor. And then after the implantation, the nylon ball is put, and then there is a lead disc to fix that catheter, and then by this way we use to deliver basically the iridium after defining the proper tumor volume where the patient need for a interstitial brachytherapy. So the sources available for the brachytherapy is cobalt 60, cesium 137, iridium 192, iodine 125. The cesium is now not only popularly used, but in form of needle tube beads after loading. But cobalt 60 source in the brachytherapy is coming up, but it's not as good as the iridium because of high energy. The source available in form of needle tubes pellets, and iridium as available as a wire pins for manual after loading, and as pellets in form of pellets for remote after loading. In the iridium, the most of the department having a iridium brachytherapy. For a carcinoma cervix treatment, having a pellets form for remote after loading brachytherapy. Iodine 125 seeds are available for a plaque form for a permanent implantation of surface applicator, precisely used more commonly in the retinoblastoma. In India, the retinoblastoma work is more commonly, thoroughly is being delivered there in the Hyderabad Apollo Hospital. And we all know Dr. Reddy is doing a wonderful job here for iodine implant, permanent implant for a retinoblastoma. But you require a very, very early lesion for that kind of a treatment. The cesium, a little bit of for cesium, that's largely replaced with the radium as a nucleotide of choice. Cesium was available in form of a compound like cesium chloride or cesium sulfide, but that compound was chemically stable. And although we know this half-life of a cesium is 30 years, so that can use 30 years? No, not at all. The recommended working half-life of a cesium is 10 years because of a mechanical damage of a source after repeated source travel. So all the sources having a recommended working life actually, and then manufacturer will not guarantee the integrity of source after the recommended working life. So that working life is basically not actually the half life. It's basically you can say it's basically decided by the depend upon the how much mechanical damage happens over the years. So that manufacturer basically give you a written that the source can be used up to this year. The cesiums are available in a needle form or a tube, small pellets for the remote after loading machine. Then again the iridium, currently widely used because of a high specific activity, means specific activity per gram is very high, and a fine catheters, a fine wire is there, so that available in you can see this 0.8 millimeter diameter, and after the source encapsulation the diameter goes up to 1.1 millimeter only, so that it is very suitable for a transfer of a source from the catheter. And an active length of wire is 4.5 millimeter length. And this wire is this iridium also having flexibility, so that it requires the shape of a tumor, and also you can cut the wire according to the length of a tumor. And the gold can be used as a permanent implant because of a short half-life. And then surface and a mold application, I've already told, is largely replaced by the electron treatment of a linear accelerator. So the cobalt 60 having a high specific activity, an X-ray constant makes it an attractive source of a HDR, but still not very popular. Gold, I have told you, in the form of a grain seeds wire with implantation gun. It fitted directly in the tumor area, but most commonly the gold is used as a permanent implant. Permanent implant means you need not to remove the after the proper radiotherapy, you need not to require to remove the seeds or implanted radioactive source. So it's not a problem, and it's sterilized, so it remains present there. So permanent implant of a gold is most commonly used in the malignant pleural effusion or malignant ascites. Iodine available in the seed form as a permanent implant or a plaque form, directly applied in the tumor area in case of treatment of a single solitary retinoblastoma limited up to 4 millimeter size, or I'm not sure whether this had gone in education furthermore. The practical aspects in a brachytherapy, the activity of source is apparent activity basically, because the real activity of a source is attenuated because of source encapsulations. The true activity is greater than this activity. So we should know what is the exposure rate constant. It's basically implies strongly here, that is gamma ray constant or exposure rate constant is defined as a dose rate in centigrade per hour at a distance from 1 centimeter from 1 millicurie activity of a point source. So this, however, redefined because of a source encapsulation. That's because of attenuation effect. So what is point source? From a single point source, gamma ray is emitted isotropically, means all around the source, and it follows strongly inverse square law. Therefore, intensity of radiation will decrease with the square of the distance from the source. So the dose rate will be proportional to the activity of a source as well as the inverse square of the distance from the source. There are multiple sources also. The 5 equally spaced line of the source each emit gamma rays in all directions, producing a complex pattern of isodose distribution. It has been seen that the point source to the source in the same horizontal point source close to the source in the same horizontal axis will receive high dose, and a points between the two sources will receive low energy. So I'll come back in the diagram to make you sure. You see here the five equally spaced source in the line. First line you see 1, 2, 3, 4, 5 sources, and from the source the energy release that you see here, the between the 2 point of a source, two sources, in midpoint the activity is low, and then directly beneath the source the activity is high. If you go further down depth, so that's this picture shows the ultimately at the certain depth you see the activity at the corner of this line, both the side of the line is less as compared to the central portion of that line, where activity is high. So the inference should be drawn by this figure. The uniformity of a dose achieved depend upon the both distance from the source and spacing between the source. And uniformity of a dose further improves by increasing the activity of source at the end of that line. So if we increase both the corner end of the source activity, increasing the activity means the dwell time you increase there and that point, so that you can have a homogeneous dose distribution on the single plane. So method of application of brachytherapy is preloading method, manual after loading, and remote after loading. The preloading is defined. The source, in the earlier days it used to happen, the source are loaded in the applicator before they are inserted into the patients. So that's used to cause great harms of radiation exposure to the paramedical staff and the clinical radiation oncologist. And because of radiation exposure to medical and paramedical staff, lead to the invention of after-loading methods. So what was the manual after-loading? The first applicator are put in the patient and the source are manually inserted to the applicators. But the most advanced version of this is a remote after-loading. This eliminates virtually the basically radiation exposure to the team involved in the giving the brachytherapy. So each applicator is fixed in the patient and the check X-ray carried out with a localized dummy source in the applicator. You see here the cesium machine, and then you can see the flexible catheter is moving from the hole to the where the patient is there in the other room, and then it is a remote after loading cesium machine, which is now nowhere practiced probably. And then these catheters are connected to the applicator and the source movements happens accordingly. So it's basically a CS cervix patient is receiving after external beam radiotherapy this brachytherapy. So you must know the source movement, combination of various source strain with the options to choose. The small miniature source with a spacer enabling the operator to create his own source configuration. So by single source with the option of a different dwell time, how much dose to be delivered to the different site at a various positions, simulating either one or many multiple source points. So that you see here in the source optimization of a dose, like you see in the figure 1, that's a simple 1, 2, 3 dots. That's a source, 3 sources are there. But in case of figure 3, you see if we increase the dwell time of first source, top source and the bottom source, that the figure becomes here is created like this. And in the last image, you can see here, if we increase the dwell time much more on the top source and the very less to the bottom source, so that this almost pear-shaped of dose is achieved. So that high dose on the top and the low dose to the bottom source. So that is called dose optimization by adjusting the dwell time of the source. So that's a figure shows that interstitial implant. This it's important to clearly define first for interstitial implant the target volume and have a pre-planned number and distribution of a radioactive source and applicators to be used. And the homogeneous dose distribution is very important because high dose around each source can cause a necrosis, and a low dose between the two sources can result in the recurrence of a tumor. So that dose should be homogeneous. The, the interstitial brachytherapy in head and neck cancer is basically the most ideal situation. Is suppose the T2 lesion, a patient operated and develop a recurrence as a node, and that node, if it is mobile, there is no extra capsular spread that it can be excised. But if you found node is fixed, on MRI you show the extra capsular spread, the only EBRT gives a very, very poor result. But by adding the interstitial brachytherapy, neck node failure rate decrease up to 20% only. In compared to when we give only external beam radiotherapy, the failure rate is almost 50%. This is a beautiful example of interstitial brachytherapy in head and neck cancer. Otherwise, we all know that a T1, T2 lesion and early T1 lesion having a good response of a tongue lesion or buccal mucosa lesion with the interstitial brachytherapy. Sometimes brachytherapy also used in the soft tissue sarcoma. After the surgery, we can use because the surgery is the gold standard for soft tissue sarcoma. We can use two different types of implant, like one is the horizontal implant, one is the vertical. Horizontal in the on the axis of a limb, if it is limb sarcoma, or vertical on the vertically along the axis of a limb. So vertical implant. So which one is to be used? Like a vertical implant required a same tumor length, high number of catheters, large number of catheters, and also the potentially risk of causing a neurovascular injury because it is directly inserted the stellates or for but vertical implant, but that not happens in the horizontal. And other things to remember in the soft tissue sarcoma, between the two catheter distance should not be less than 1 centimeter or should not be more than 1.5 centimeter. So these things should be kept in mind. And the finest indication, the low grade soft tissue sarcoma, brachytherapy used if a tumor size is more than 5 centimeter or if it is a recurrence, and the dose which give the 36 gray in 9 fractions, the high dose radiotherapy by brachytherapy we deliver. During the implant catheter, care must be given to protect the neurovascular bundle so that the implant and between the two implant and the neurovascular bundle, gel foam or a spacer is used, avoid the neurovascular injury. You can see here in the carcinoma cervix patients, brachytherapy, you can see the vaginal cylinder, tendon, skin template, endocavity interstitial needles, vaginal cylinder, so that we can go for brachytherapy in carcinoma cervix. We have just shown we have applicator with a CT compatible, MRI compatible applicator as well. In contrary to the old traditional, the X-ray compatible applicator, Fletcher and Shoot. Also brachytherapy used in the breast carcinoma, early breast lesion, but the most important indication nowadays evolving at the accelerated partial breast irradiation, when we do not irradiate the whole breast in order to achieve a good cosmosis and good cosmetic results, we can go for a accelerated partial breast irradiation. And an indication of in this kind of a brachytherapy is the patient age must be 40 years. There has to be a BCT case, but be aware that all BCT is not fit for the accelerated partial burst irradiation high dose brachytherapy. Only 15 to 20% cases of after the BCT is deemed suitable for this form of treatment, APBI treatment. And their histology should be the ductal carcinoma in situ or a ductal carcinoma infiltrating early lesion, T1. Margin should be negative, as closest margin should be away from 2 millimeter, and there should be no axillary lymphadenopathy. There should be no lymphovascular histology. So with these are indications, so that you see here the brachytherapy catheters are put, and which plane? There is a two plane of radiotherapy. One plane you see, and the other plane, there is a two plane. There are single plane, two plane, three plane brachytherapy. So what is the interstitial implant rules? The Paris rule: the active source should be parallel in state. Lines should be equidistant, and between the two lines there should be at equal distance, and a line and a plane on which the midpoint of the source lies should be right angle to the axis of the source. So that is very important, that the source should be the right angle to the line of implant. Linear activity of the source should be uniform along the entire length and should be higher 25 to 30% at the corner of an end, that I have already explained why. The separation between the source or two plane should be vary from implant to implant, but between the two source the minimum space required 8 millimeter and for a small volume tumor, and maximum 20 millimeter. An average length I have already told you. This thing you see here, the interstitial brachytherapy where the implant is being done, and there is the loop technique as well, that you do by it's a diagrammatic view. And also you see here the single plane implant, and then loop technique you see here. That's a form of interstitial brachytherapy. So the Paris dose calculation based on the distribution of source in the central plane, that is the plane which at the right angle to the axis of a midpoint of the source. First we calculate the basal dose rate, which represents the dose in the center of implant volume and defined as the dose rate at the point in the middle of the pair or a group of sources where the dose rate is lowest, that is the basal dose rate. In case of a large implant, there may be several pairs of a group of sources arranged in the triangles or square. For these, the mean basal dose rate is taken. The basal dose rate, a point that summation of a dose contribution from each source obtained from a graph of a dose rate variation with the distance from the source. So you see here in the figure A, you see the two plane, one plane and two plane, and then you midpoint, and then you center, you decide the basal dose rate in the first triangle. And the second triangle that you in the second plane, double plane, you made it two triangle, so that you take a basal dose rate 1, basal dose rate 2, because of two different two triangles, and then take a mean, and then you can see. And the second figure explain here the source axis should be vertical to the plane of implant. Once the basal dose rate is calculated, the reference dose rate is taken, consider as 85% of basal dose rate is a reference dose rate. This serves to calculate the duration of implant, and the 95% isodose defines the treated volume. A value of 85% is being chosen to provide an isodose contour that reasonably covers the target volume with accepted variation between the dose at the center and that at the periphery of the target volume. The time for which the implant must be left in place is delivered by dividing the prescribed dose by the reference dose rate. How much dose you have prescribed and should be divided with the reference dose rate which you have find by the help of basal dose rate. So it used to be done in earlier, but now there is all the problem is solved by the 3D treatment planning system. So here you see how we have calculated superficial plane, 2 wires, deep planes, 3 wires, so that superficial and deep planes, and then how we calculated the type. Nowadays it is being done by the treatment planning system. The rationale of low dose rate brachytherapy, it has been known that many decades that lowering the dose rate generally reduces the radiobiological damage. The explanation of this effect relating to sublethal damage repair also is being long understood. The increasing the dose rate will increase the late effect much more, and it will increase the tumor control conversely. And decreasing the dose rate will decrease the late effect much more than it decreases the tumor control. Thus, therapeutic ratio has to be maintained, and a ratio of a tumor control increases as the dose rate increases. The increasing the dose rate will increase the late effect much more than it increases the tumor control. Thus, the therapeutic ratio is being done. So you see here the early effect and the late effect, the alpha beta ratio, beautifully explained. That's a cell survival curve. As you see, then one axis the dose, one axis the surviving fraction of the tumor. It's a Jack-Flower linear quadratic model. The observation can be interpreted in terms of alpha beta ratio. In the terms of survival curves, the alpha beta ratio essentially describes the degree of curviness of the acute survival curve. The smaller the value of alpha beta means the beta dose is squared. This is dominating at radiotherapy dose, resulting in a curvy survival curve, shouldering. And increasing the dose rate will increase the late effect more than it will increase the tumor control. Thus, the therapeutic ratio has to be maintained, and then increase the dose rate. Increase in the dose rate decreases. The another thing we should understand the biologically effective dose. If we know how to calculate the biologically effective dose, so that different protocols, fractionation protocols can be compared, and BED is a measure effective units measured in the gray, where suffix x indicate the value of alpha beta ratio assumed in the calculation. You see the formula of biological effective dose. So the dose rate and ICU recommendation way back in 1938, probably LDR 0.4 to 2 gray per hour, MDR 2 to 12 gray per hour, HDR type of a brachytherapy considered is more than 12 gray per hour. Most of the LDR, MDR, cesium as a source of, but HDR, iridium 1 and 2 and cobalt 60 as a source. So that since the carcinoma cervix, the heavily involved the brachytherapy, so that ICRU 38 recommendation is given. The treatment of technique must be described. The reference volume should be described in terms of height, width, and thickness of a volume in close and 60 gray isodose for LDR treatment in carcinoma cervix. Why they have to do it? Because we know the cervix is a uterus is usually antiverted, antiflexed, but if uterus is antiverted, antiflexed, everything is fine. But if suppose uterus is retroverted, retroflex, what will happen to the point A? The point A will be changed, but point B will remain on the same axis, but the point A will change, so that all the calculation will be different. So they recommended to calculate the reference volume and accordingly treat the tumor. Also, with this on the TPS, you can see the absorbed dose at a bladder reference point, rectal reference point, lymphatic trapezoid point, and a point A and point B. So, because the external beam radiotherapy in carcinoma cervix, you usually give 50 gray. So, the leftover 35 gray because we know we have to treat if a cervical cancer. We need 85 gray, like advanced stage cervical cancer, we required 85 gray to point A. So what will happen to 35 gray after 50 gray, because the dose bladder and rectum as a limiting organ, so that we usually deliver the 35 gray, so that 35 gray of 60%, that's a 35 gray is LDR, but we convert the LDR to HDR, the 60% dose reduction is there, so it comes around 18 gray. So the 9 gray 2 fractions or a 7 gray in the 3 fractions, we can deliver radiotherapy. So you see here the point A and point B. Point A is 2 centimeter up to the os marker, and then 2 centimeter lateral to the center of the uterine canal. On the same axis, on the 3 centimeter, there is a point B. So the dose coming to the point A, and then since we know the inverse square law is strongly applies here in the brachytherapy, so the point B dose will be 1/3 of the dose which is delivered at the point A. You see the check X-ray is done after the applicator put in the seat, and this thing after the manual, this thing after the application of catheters, central tendon, you see that a tip of central tendon is entirely bent little bit in order to protect the bladder and rectum. You see here the Fletcher and shoot applicator along with the sorbo application applicator. The cylinders are there, and then you can see the different thing by lymphatic trapezoid point and how we calculate the lymphatic trapezoid point. And then you see here in this picture, the second picture, that's from the anterior surface of L2, L3 vertebra, on the corner of that up to the the pubic symphysis, the midpoint from, we calculate the midpoint of that. So other figure you see here, the balloon of a catheter balloon with dye is filled there. So the bladder reference point you find on the intravaginal sources, posterior vaginal wall. You can appreciate the rectal reference point 0.5 centimeter behind the posterior vaginal wall, which can be confirming by the putting the impregnated barium gauge piece, which can picked up to the posterior wall of vagina, so that you can measure the 0.5 centimeter distance dose, that is the rectal reference point. A CT scan is also used as an interstitial brachytherapy in case of a carcinoma cervix, and more commonly it is useful as in form of 3D CRT or in form of interstitial implant, particularly in case where the tumor is in advanced stage 2 to 4, and the geometry of tumor is grossly distorted, anatomy of tumor is grossly distorted, so the applicators are not going inside, and then a difficulty in passing the applicators we can give with the 3D CRT leftover 30 gray dose by the 3D CRT system. You can appreciate the rectum, the target, the cervix, and the urinary bladder here by both the side, the femoral head. So the isodose is calculated after taking a CT scan, then a contouring done, and the isodose distribution is seen, and the delivery of radiotherapy. So what is the take-home message for a brachytherapy? Basically, brachytherapy, I personally feel, has to be there in every department of a medical college or institute, because there is no alternative to brachytherapy. except the portion of surface mold therapy, which is replaced with electron treatment with the same result. So finally, we say the take-home message is brachytherapy planning required a military discipline. Radiation oncology must be fully aware of each and every applicator and about its dimension and length. The third point is the tip of applicator, and the first dwell point must be very clear. And then the fourth point is extension of a third point, that the travel of a source from a catheter tip to the first dwell point is called indexer length. And then the fifth point is after the implantation is done, the CAT scan is ideal to get it image, acquire the image, and then do the treatment volume delineation and treatment volume treatment planning, and then this way we go through the brachytherapy. So thank you very much, dear friends and viewers. I again repeat you to call your colleagues and to ask to subscribe this channel in order to give you a boost my morale as well, and then keeping the lectures continuity ahead and more frequently and more passionately. Thank you very much.